Hello, everybody, and welcome. Today, we're having this podcast with one of the greatest endodontists in the world, Steve Buchanan, and I'm really honored to be able to call him my friend. He's the inventor of the GT file, of the endobender, and of System B. Maybe he will do the rest of the introduction. Hi, Steve.
Hey, so great to be with you, Simeon. I have been doing root canals for 45 years, if you can believe it or not. I still will leave the floor to you to ask the questions, but
Okay.
I'm really psyched to be here. Thank you. It's a pleasure and an honor, and I'm honored to call you friend as well. It's been great getting to know you. Dr.
Thank you,
Roitman has
Steve.
a very creative mind. He's very fast and quick to get things, and also has a great sense of humor. So I think this is going to be a good time.
So I would personally, I hope our listeners too, but me personally, would be very interested in hearing your point of view on how did endo change in the last 45 years.
Right. When I came into Indo, I went to school 78 to 80 at Temple University. That was when the biologic school with Sam Seltzer and Kerry Langland and all those histologists. And the other side, we had Herb Schilder, who, in my opinion, really brought technique back to Indo after we recovered from the focal infection era. So I got taught to do Schilder technique in undergrad. I went to University Pacific. They had no graduate programs. So if you're interested in endo, they give you all the hard cases, and it was really fun. My instructors told me to read Herb Schilder's stuff, and that was the first thing I'd heard in endo that made sense to me, because I'm the dental student in the class that's going like, I don't know anything about anything, but that thing you just told me about why we don't have to treat the whole root canal doesn't make any sense at all. And Herb Schilder goes like, no, you have to treat the whole root canal. The level of your success is exactly proportional to the completeness of the treatment of this interior space that we can't get antibiotics and immune cells to. And so I got trained in the Schilder technique in undergrad, and then I went to Temple University, which Herb and Sam didn't like each other at all. So we never had guest lectures from one or the other. But Sam was a histologist. He was self-admittedly a really bad clinician. I mean, he'd show cases that were just horrible, and then he'd show a 25-year result where it worked out. You see a gutta percha cone like looking like a Z pattern in the middle of a cuspid, and they go, and here's 25 years. so so I got brought up in the specialty hearing both sides. And those are the two major voices. The biologic school is saying like we got to have science, we should know what we're doing in here on a cellular level. I can't disagree with that, but if you miss the forest for the trees, it's not going to help you out. And I think a lot of the histology profs who don't practice have given us rules to adhere to during root canal therapy that make it very difficult to get good results.
You were one of the people who was in the beginning of the era of the invention of the night eye instruments. And you
Uh-huh.
started with the Schilder technique, with the step back technique. So, what was the thinking behind let's do night eye?
My first invention of files was the realization that we need different tapers of files. All we had was K files. All our files were O2 taper. And so the only way we could create a tapered preparation was we use increasingly larger tip sizes of instruments fitting, even and perfect increments back from each other. And we indirectly cut a tapered shape. And so I did that in grad school. I learned how to do it. That was the Boston University shoulder technique, serial step back shaping. And one day I just had the epiphany. It's like, God, we're working so hard with all these different instruments. There's like 12 to 18 instruments. And it took 20 to 30 minutes to shape one root canal.
Whoa.
And so my first epiphany was, why don't we have tapered files? Why don't we just have files that have the taper that we want to end up on? It's like not that difficult to think, right? Well, I got the answer.
Yeah.
The first three prototypes are out of stainless steel and they broke immediately and they did not work. They're stiff as a board. So sometimes the answer you get to a burning question is nope, we can't do that. But um, sometimes it's more important to be in the game, in the hunt, than it is to know exactly where you're going to end up. And invention is you never end up where you think you are, or very rarely do you. And so just because I was in that realm of prototyping files, even though they weren't working. Um, right at that time, the guy that's prototyping my files says, "Hey, there's this new kind of wire that's hyper flexible and super tough in torsional resistance. loads, and it's called nickel titanium. We could try to make your next prototype out of that. What do you think? And I said, it's like you said, it's 5 times the strongest stainless steel and it's hyper flexible. Yeah, let's do that. And so the next file that we made was GT hand file, literally the exact thing, and it worked perfectly the first time. And that was the first single file shape ever. And it was in 1989.
You sound very courageous. Can you describe this moment, like in time? How did people react to you coming to them and saying you have been doing it all wrong?
Well, let me back up a little bit and further introduce myself. I have severe ADHD. So the worst thing for me is to do the same procedure for the rest of my life. That is hell. So it's not courage, it's like intense boredom. It's like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I'm so bored. I can't stand this. We got to do something different. So it's not hard for me at all. The hard thing is when once you decide you have this mission statement, uh, the middle part really sucks because you're spending money, you don't have any results that work, you haven't licensed it yet, your patent attorney just sent you a bill for $7,000, and it gets worse and worse and worse until finally it goes to market, and then you're an overnight success, right? So that, but invention for me is always, I've always joked that if you want to invent things, you need to be continually dissatisfied. It's like these cotton pliers suck. Half the time I pass it to my assistant, the paper point drops out. I fucking hate these things. And then you come up with locking cotton pliers, right?
What would be your three best advices for people who are just starting in endodontics?
Well, the first one, I got turned on to endo in undergrad, my undergrad program at UOP. Alan Gluskin was my floor instructor. And I go, Dr. Gluskin, what's the most important skill to have to do great endo? And he told me something I totally didn't expect. I thought it was like some hand skill. He goes, no, it's what goes on in your head. It's how well can you build an accurate mental picture of what's going on in this hidden space you can't see, this tortuous little space. And so the more accurately you can mentally visualize the space you're working in, the more capable you are of avoiding problems, also deconstructing what happened when things don't go right. One of the biggest problems in endo is it's really hard to deconstruct our failures. And that's why we have so many ridiculous solutions to non-existent problems. you know,
Yes.
and that's a large proportion of our specialists.
I think it's the first time I'm hearing this advice. And actually, I started to film lately with my head mounted camera. And when I was editing the videos, I noticed that half of the time or more, I'm not actually looking at the tooth. So when I work with the tooth, in my mind, I'm also looking at the tooth. But when I watch the video, half of the time my head is turning and the camera is not on the tooth. And I realized that all this time I'm keeping the mental image in my mind.
It's a mental process. It's what do you think about when you're doing a root canal? When you have a rotary file in a canal, what are the things you're thinking about? I'm thinking about how fast the RPM is. I'm feeling about what the tactile feedback is. I'm building a picture in my head of like how full are the flutes with cut debris, because as soon as the flute's filled with debris, everything's going to get worse after that if I don't take the file out. Same thing with obturation. I'm getting ready to do a backfill. I'm thinking about how do I make sure I don't get a backfill void. Don't forget to give a sustained condensation force right at the very end. I'm talking to myself through the whole procedure because even though I've done it for 45 years, I'm not doing anything the same way I did 45 years ago, virtually nothing. And so it's always a new storyline that's going on. One other thing, if
Yes.
you couple mental imaging skills with becoming a student of endodontic anatomy, those two things are those above all everything else, those will guide you to get to successful clinical results eventually.
But what do you mean by saying become a student of the anatomy? What does it actually mean? What actions should one take to become a student of the
Right.
anatomy?
First off, look through Walter Hess's book online. Walter Hess in 1925, so 63 plates of teeth that were cleared and then spun in a centrifuge with India ink to disclose the canals. He also injected vulcanite rubber into cleaned out root canal spaces and extracted teeth, and then dissolved the tooth structure away with nitric acid, showing these little models, intricate models of the anatomy. And so it starts from, well, what's the literature say about the anatomy? And the literature is never going to tell you anything about the tooth you're treating because nobody's tooth is average. but it's going to show you the range of anatomy that you're going to encounter. What do lateral canals look like? Where do you expect to find them? What do accessory? What's the difference between an accessory canal and a lateral canal? What do our pulp horns look like? With this greater understanding or constant tuning of what the anatomy might be in a root canal, you can intuit what's going to happen. So if I've got a root like this and there's a lesion off the side, it's coming off the apex, but it wraps down the side. Instantly in my head, I've got a lateral canal into the side. Here's the primary canal. There's a lateral canal. That's why the lesion is asymmetric about the apical portal of exit. That's why I would always prefer to treat a necrotic case because you get pre-op hints as to where the portals of exit are. Vital cases are much harder than necrotic cases, even though people usually think of them differently. They go, oh, the necrotic case is infected. That's the dangerous one. It's like you don't have any clue. The vital cases are way more difficult because you're fighting this structural element, this connective tissue in there that wants to wad up at the end of the root canal and block you out there. Um, Harder to get patients numb. It takes way longer to digest vital pulp tissue that's inflamed and dying in lateral recesses than it does to clean bugs out of a biofilm. Biofilms are nothing compared to digesting vital pulp tissue. Um, uh, yeah, and so when you have roots that look straight and there's a lesion only off to the side, then you automatically know that the canal goes up. And this is typical in distal roots of lower molars and distal buccal roots of upper molars. And that is that they come down in a straight root and then they just take a 90-degree kink and they exit on the side of the apex, not at the apex of the root. So that's just the most fundamental stuff. The really complicated mental imaging is what's my file look like in there? What's it doing? Where is it feeling strained? How long has it been cutting since I cleaned it out last? I'm coming into the apical part of the root canal where I'm going to load debris quicker. How much of a cut can I make before it's full? Because it might only be advancing one more half millimeter in there, and I should take it out, look at it, clean it off, and put it back in there for that last little half millimeter cut.
When I was just studying in endodontics, my professor gave me the keys of his studio, and I had like a huge jar of extracted teeth, and I would
Oh,
break many files. And after I broke a file, I used to take a tooth and cut it, and look at the place where I broke the file and try to understand why. So you talked about deconstructing. So deconstructing failures.
great topic. Very, very difficult. Very difficult because we're working in a space that's hidden. It's tucked into our patient's jaw. We can't even see the outside of the root unless we have CT imaging. And when things go awry, it's not always that you did something wrong in that procedure. You may have changed a little part of your instrumentation procedure to say, you know what, I'm going to hang out and cut a little bit longer in each of my cutting cycles, and it works great 3 or 4 times, and then you break a file on the fifth time. And you're starting to think back, like, what did I do different this time? I'm doing the same thing I've done for the last 4 or 5 cases, and that's true, but the chickens don't come home to roost every time you make a mistake clinically. So if you push on a file 4 out of 5 times, it's going to be okay. And the fifth time, it's going to break. I always talk about there's two little voices in my head at all times. And so when the file slows down, it doesn't want to go any further. Uh, the uh, the office manager goes, "You need to keep at it there. Let's be persistent." And then the clinician on the other side says, "No, I'm afraid we're going to break the file. I think you need to take it out. Maybe even get a new file." And then the other voice goes, "Did you see our file bill last month? Did you see the reception area? There's 5 people out there waiting to get in here, and you're goofing around and not getting this thing done. Get it done. Give it a push." And 4 times out of 5, it works out great. So that's one thing to think about. I'll give you an example of deconstruction in real time. I was doing a live demonstration on an upper molar for the graduate students at Oregon Health Sciences University in Portland, Oregon. So, first mistake I make in this case is I let them pick the tooth. Well, it's an upper first molar and the MB root. I swear to God, I don't even think I've seen one with this much curvature. It had like 110 degrees, 120 degrees of root curvature on the MB. So I look at that and go, why did I let them pick the tooth? I should say, give me a bunch of radiographs and I'll pick the tooth. So fine, we're gonna do it. I'm showing my GT rotary files, and I'm just so afraid that I'm gonna break a file. I actually put a brand new rotary file during the process of cutting that shape. I finally teased and cut a 2006 GTX file to length. And I'm just going, okay, now it's time to gauge. I'm going to put my K files up there and find out what the terminal diameter of the canal is. so I can figure out what my final shape needs to be, right? Because whatever the original diameter is, I want to maintain that. And I need to cut a shape that ends with that as the smallest diameter. So we gauge with K files. Once we cut initial shape, we slide K files of increasing and larger diameter to the end. And when one of them binds right at length, we've it's not perfectly accurate, but we have a good indication of about how what that diameter is, and then we just choose a finishing file with the same tip diameter. Well, um, the larger your tip on a file is, the stiffer it gets. That's very obvious. But so my concern is I get the 2006 there, and I'm worried that my 20 is going to go through, my 25 is going to go through, my 30 is going to bind at length, and now I have to cut a bigger, stiffer file around 120 degrees of curvature, and I'm going like, please God, don't make me do that. I don't want to break my files in front of these guys. They'll never use them again. And I gauge, and my 10 slips through, my 15 slips through, my 20 binds right at length, and my 25 and 30 step back, and I'm going like, thank you, Jesus. Now I have to go to Easter services at church, but it's worth it. And so I realized that my 2006 shape has completed the needed taper at the end of the root canal, fit a cone, obturate, take a radiograph, and I overfill 4 millimeters. So my fill looks like this, and it's like it's so long, it's got its own zip code. It's like if you ever had to do surgery on it, you just like lay a flap. It's like, well, there's the gutta percha. It's like there's this
Oh,
flag going, treat me over here.
can't
so
imagine
so
how
I'm
would you feel like in front of all the people.
all
It would have been.
I didn't see it, but I think all the blood left my face. And I'm just looking there kind of stunned with my mouth open. It's like, huh. And I said, okay, you guys, I'm going to go to the bathroom and have a little talk with myself. I'll be right back. And I
Oh my
left.
God.
And so I go back in the bathroom. Thank God nobody's there. And it's like, okay, Steve, what are you going to do now? Geez, this is like, what does this mean to you? What does this mean to you? Are you, should you stop doing these live demos? What I came up with is I finally realized I had this epiphany. It's like, oh no, I haven't bummed these guys out. This is going to be one of their favorite days of their graduate program. Is remember the day Steve came and shot that mile of gutter perch out the end of the root canal? They probably have a videotape of it somewhere that they watch at lunch. I realized that the best live demos actually are when you get in trouble and you get yourself out. So that requires a huge leap of giving up a big part of your ego for the objective, which is to share something with somebody else so that they can learn and do better as a result of it. And when you do a procedure and it's all perfect and it comes out just exactly right, they learn what you did, but they don't know anything about when it goes awry. So that's why they prefer those. Well, back to the subject. So I come back out of the bathroom. I said, let's go in the conference room and have a chat about this. First off, we need to assess the risk to the patient. Second thing, we need to deconstruct the failure. And the third thing, we need to change our techniques so that this doesn't happen again. Being a professional means you're still going to make mistakes, but if you're accountable for them, you go through the mental process and you make changes in your procedure to refine and reduce that variable and get it out of there so you don't have to overfill 4 millimeters in front of a graduate student anymore. So first, you need to assess the risk. What's the risk? The risk is that this overfill is going to cause failure. Well, I just gave you guys a lecture on the fact that overfills don't cause failure. And that's a whole separate topic for an hour and a half. But the gutta perch is biocompatible. The sealer is biocompatible. Um, the canal is sealed because I slid this gutta perch so far out the end of the root canal, a bigger part of the gutta percha cone ended up at the end of the root canal, and it's cork. I just shoved this massive cork to the end of the root canal and just had extra. And one of the jokes that Herb Schilder used to always tell when a patient would say, "Well, well, what's that stuff at the end of the root?" He goes, "Oh, that's a little surplus sealer." And they go, "Well, tell me about that. Is that a problem?" He goes, "No, there's no extra charge for that." So anyway, so the risk to the patient is we're not going to go back and do surgery. Almost certainly this is going to work, and it did. It's a ugly case like that will never die. That patient will never have the tooth extracted for an implant. It's here forever. So then the next step is deconstructing the failure, and so I said, let's do a differential analysis. What are all the possibilities that could have caused me to overfill? Misfit cone. Um, Misgauging was one of them, obviously. Pushed too hard on the gutta percha when I was sealing it. And I think there are two or three others that we came up with. A manufacturing defect. One clinician's favorite thing is like, oh, there's a manufacturing defect in your files. I broke two files in the same tooth. Is like, yeah, no, that's not a manufacturing defect. You need to go back to school. But
Oh, that's a
anyway,
manufacturing defect of the parents. Might be
yeah, right, right, right. Of the manufacturing
manufacturing.
defect of the clinician, right? Yeah, right. Yeah, you can't fix that. Can't fix bad DNA. So the most likely, we all voted. It's like, what's the most likely possibility that my shape was incomplete? That I had a 2006 shape and the end of a root canal was zero point 0.3 millimeters at the end. So the last 2 millimeters of that root canal were not tapered. And so the cone was binding at the shank end. When you bind a cone at its very tip in a taper prep, you can't push it through the end of the root canal if you try. If you bind it, you have an incomplete shape and it binds back on the body of the cone, that thing's gonna it's gonna rocket out the end of the root canal. So we figured out it was a gauging error. Well, how could I have had a gauging error? Well, I was using stainless steel K files, and the curvature was so great that I felt the file stop, thinking it's binding at its tip, but it wasn't. It was binding in the flexure in the curvature. The stiffness of the blade stopped the file. And, I'm not going to push on it because I don't want to enlarge the end of the root canal. And so the diagnosis was gauging inaccuracy due to the stiffness of the files. And so now we're up to the third part of the process, and that is what are we going to do so this doesn't happen anymore? And that's when I went to using nickel titanium K files for gauging.
I'm really amazed how did your mistake and your accountability and your willingness to confront your mistakes. So you need to be courageous to come to a room full of students and say, okay, this is what we got. This is the mistake I did. Let's deconstruct it. This takes endless amount of courage.
I had 8 witnesses. I didn't have any choice. This is my best riff that I can come up with. What am I going to go out there and say? Well, some days I'm pretty good and some days I just suck. Today I sucked. That's not going to help them out.
The K nickel titanium file, was there on the market or did you
Uh-huh.
invent them or ask? They
Mm-mm.
were on the market. No.
Right. Yes, they were. The first files
Uh,
made out of nickel titanium were just normal K files. And then we figured out, oh my gosh, this stuff's so strong we can put it in a handpiece and cut shapes with it. Because the stiffness of files causing the problem, the most obvious answer was let's change the metallurgy. Let's use a hyperflexible a metal like nickel titanium in K files. So they're still very super flexible because they're so narrow a taper, and they'll easily pass to and through the end of the root canal. They'll never hang up around a curvature, and that turned out to be true. My apical accuracy improved dramatically. I didn't. I I haven't overfilled like that since then. So what's the message here? That's the kind of process you need to be going through in your own head instead of saying, "Oh, that was a one-off. I broke a file. That's probably not going to happen anymore. What are the odds it's going to happen again today?" Dink. That's when the second one breaks. My favorite broken file cases of all time are the ones where there's a broken file in each of the four canals in an upper molar. And if you think about, so let's think about that clinician's process. He's going like, "Rah, rah, rah, rah," think, ah, shoot, I should have gotten a new file. Rah, 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 think, oh my gosh, that's two of them. Who keeps working on that tooth? Who puts another rotary file in the next canal?
I think it's going to be rule number 3. So we said one is imaging, mental imaging.
Mhm.
The second one was to become a student of anatomy. And rule number 3 or advice number 3 would be own your failures. Own your failures
Yeah,
and deconstruct them and
yeah.
try to learn from every failure. It's really, really good advice. And you
Thank you.
also have a project that teaches anatomy. So what was your approach and what is your approach right now for teaching anatomy online and in person?
I started printing 3D replicas of teeth about 8, 9 years ago. And the reason I got interested in 3D printing was I did a root canal on the guy that invented it. So he's a physics professor at UCSB, Chuck Hull, great guy. And I finished the root canal, and I always look at my patients, patient forum to see what they do for a living because I'm waiting for this is back when we had to get X-rays developed. So I'm waiting for X-ray. I got nothing to do. I'm going to talk to him. So I always look at their occupation, and then maybe there's something interesting to talk about. He's a physics professor. I go, oh, you're a physics professor. What's your area of interest? And he goes, I invented this thing called stereolithography. And I said, "What's that?" And when he described the fact that you could take a computer model and create a physical replica of it, um, I thought my hair was going to light on fire. And the first thing I said to him was like, "Could we print a tooth?" And this guy's so smart. He goes, "No, it's too expensive, and the resolution sucks. It'll be about 20 years before that happens." And it was 22 years after we had that conversation that the technology, the patents came off. The first patents expired. Then you get all this creative new kinds of inkjet printing going on with multiple inks, and we were off to the races. What are the advantages of replicas? Well, all the most difficult things that humans learn how to do, whether it's being shot into space or being the first violin in an orchestra, you only get there because you learn by iterative process, practice, 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 doing it over and over and over and over and over again with this thought process in the back, tuning it, making sure it comes out more and more and more and more consistent. So the first advantage of replicas is if you are in an extracted tooth and it has an apical hook to the canal and you munge it by grinding a K file into there and cutting a ledge into the impediment. Well, you don't get a do-over. How do you learn how to manage that? Well, you have to wait until you come across randomly another extracted tooth with that kind of anatomy in it, and hopefully you'll figure it out this time, but you probably won't. With replicas, you could do 19 of them and fail, and if you get it on the 20th try, you own the technique and the skill set. So that's super important. The other great thing is it is one of the easiest methods of teaching uh, mental imaging is we start them all in clear replicas so they can actually see the canals inside the roots. They can see the lateral canals, the isthmus spaces. They can see the curvatures. They can see when their file digs into the side and ledges the canal. Replicas are super ledgy because they're just plastic. But if you can learn how to not ledge a replica, you'll never ledge another tooth in the rest of your career because it's just the ability to stop when you meet resistance of a certain type. So we teach them first in the clear teeth, and then they do the same exact anatomy in opaque. So now that they can't see the anatomy, they've got to mentally visualize, okay, here's where the canals bifurcate, and I got my bent file up there, and okay, there's the entrance to that accessory canal. I'm going to give it a little wiggle and pull on it, and you already saw yourself do that in the clear replica. Now you're just going to try and repeat it without being, it's like, okay, now put the blindfold on me. Let's see how this works. Another thing I would mention as very, very important in learning how to be a better endodontist or dentist doing root canals is your imaging, your radiographic imaging. Okay. If you have a CT scanner in your office and you're not taking scans of every patient you do a root canal on, you're missing an awesome opportunity to learn more about anatomy, to save yourself the heartache of broken files with hidden anatomy. All the most serious curvatures and root canals are in the hidden plane. You can't see them with a conventional film. Plus, you can't see diddly about periapical lesions on conventional radiography because of all the anatomic artifacting of just layering all that. You're looking through the whole volume at the same time instead of just this little slice where you can see exactly where the PDL is. I take almost no working films. I don't ever take a length determination film because I'm using an apex locator. Um, and I'll take a cone fit film because that's my last chance to get it just right. But most of my imaging is a lot before and a fair bit afterwards, depending on how cool the case is. If it's a really cool anatomy, I'm gonna I'm gonna irradiate you seriously in a serious way before I get done.
So Steve has an amazing hands-on virtual training course in which you can get at home the clear teeth replicas and the opaque teeth
Hmm.
replicas and all the necessary instruments
Hmm.
and the online video how to do everything. And then you can actually come to him and train in his hands-on course. But can they buy only the replicas and the video course? Is it possible?
Once we had this the virtual hands-on training course for access, we decided to add it as a pre-course for a 2-day hands-on course. 2 days is not quite enough time to do a great job on access and the other things that we need to talk about. So we sent it home to them first off to do a market test and see, do they like this? Do they like it? They love it. They are they accomplish twice as much growth in skill sets at the end of my 2 days because they did the virtual training course beforehand. I've always wanted to create as many entries into our educational system as possible. If you don't have any money, you can take a free online course. Um, and if you watch some of the free online videos, you can figure out how to do some of these procedures in patients even. But this is the next level in. You can avoid the travel expenses, the hotel expenses, but the most expensive thing for taking a hands-on course is the missed production, the lost production when you're not in the office working. And that that's like as much as all the other expenses, maybe including the honorarium. So, or the tuition. The last challenge to learning a new technique is you won't have the right tools. You come to Santa Barbara, you use all my tools. I got every tool that you're going to need, all the stuff, all the electronic, electromechanical devices. You get home, you don't have all that stuff. So the last part of this virtual hands-on training course, it always includes all the instruments you need to do the procedure. So after you get done with this course, you still have the Stropco irrigator that goes on your triplex syringe, and you can put little different tips on it so you can hose access cavities out really well. You still have a DG16 straight and bent. The bent DG16 is the key to finding MB2 canals. You still have the orifice wideners, et cetera. So I think having looked at all the components, all the stepping stones to learn a new procedure and what the hurdles are, I think this is in some ways better than coming to Santa Barbara and having me teach you in person. Because let's look at it. You come into my lab and we're going like gangbusters for 2 whole days. All right. We have a little lunch, then we go back and we hit it really hard. Everybody gets worn out after a day and a half. So that last half day, everybody kind of slows down. I usually give a little bit more of a lecture part of the process. But when they're doing this virtual hands-on training course at home, it's like, hey, we had a patient cancel. Let's do the access on the upper molar and the clear upper molar. You do that and you only spend half an hour doing it, and then you're on to something else. Way more effective to train in short little sips than to do extended training times. And so I think that was an unintended uh, positive unintended consequence of the virtual hands-on
I
concept.
saw a video of you doing another thing with those clear teeth. You do this almost magical movement when you find the lateral canal by clicking the file into place with the clear tooth.
Yeah,
And I don't think it is possible to. Where would you find five teeth with lateral canals in order to teach this technique?
yeah.
Can you tell something about this technique for people to imagine and to want to do your course? Because I saw you do it on a video and it was amazing. I think it's such a mastery of manual skill and dexterity. I've never seen it taught nowhere.
Oh, well, also it includes a bending plier that actually will bend the last flute of the file, right?
You talk about the endobender.
Right, right. Yeah. So if we use hemostats or we do this ribbon curling thing with our cotton pliers, it turns out all that curving of little 08s and 10s and 15s totally didn't help us at all. It's useless because if you put that little curve and here's your file, it's got this nice subtle curve to it. If you grab the end of that 4 millimeters back from the tip with a hemostat, lock it in place, look at it magnified, it's straight. You're looking at a straight instrument there. That's the part of the file that meets the irregularities trying to dance around. So to not understand that very, very last flute is actually the only one that needs to be bent, because if it gets past the impediment, the rest of the file is going to follow. I don't think everybody's thought about it like that. So that was the first thing I invented was the endobender plier. And good news, they've been hideously expensive when Kerr sold them, and then Kerr finally gave it back to me. We've had it made in China out of virtually CNC machine billet steel, and they're really beautiful, but they're like $350. I have been working with the original manufacturer in Pakistan, and it's going to be half price. I think we're going to have endo benders available for something closer to $150 than. Mhm.
Under this video, I'm going to put a few links. So I'm going to put a
Great,
link to Hesse's book. So it's publicly
great,
available online for free. You you can look at this book. I'm going to put a link to your course and to the free
great.
videos on your website. It's all there. So if you want to learn with the free videos, it's also on the website. And
Awesome.
if the product will come out when the video is out, I'm gonna put the link into to it. If not, you just can join the mailing list on the
That
website,
would
and I'm
be
sure that Steve will send you an email when it's out because I'm very interested in this product, And I hope you are too, because
Thank
I
you.
always
No,
wanted to
no,
buy it, but it
I
was too
got,
bloody expensive. I'm not
I,
paying $300 for a piece of
no, I
metal.
know it's too expensive.
You said in this conversation that you had a material beyond the apex and it's not a problem. And when I teach students, this is one of their biggest fears. So they have a fear of perforating and they have a fear of overfilling. And you say that overfilling it's not a problem. Can you talk more about it? Why is it not a problem?
One of the most consequential misunderstandings we have about endodontic therapy is that surplus filling material causes failures. If you don't overfill, it doesn't matter. But if you have overfills, you need to understand what the risk to the patient's tooth, the endodontic case being successful is. And if you're worrying about the wrong thing, then you're not going to be able to deconstruct your failures and improve your technique at all. You're going to keep having the same problem like Groundhog's Day. So overfilling, you have to understand how we came up with this. I love history. I like history because I always want to know, why do things work the way they do? And so many things that we encounter in our lives, they're not logical with our frame of reference. So you got, well, somebody's life is better because they're doing it this way. What's their motivation? Why do they think this way? And so you have to kind of do a detective game and go back and, like in our case, read the literature and find out, what were they talking about? How did they come to that conclusion? And how does that project forward to the misunderstandings that we have today? And this one is a really fundamental one. And it was, if I hadn't gone to Temple University, I wouldn't know this, because it was Sam Seltzer who set everybody up. He was a brilliant researcher. They did research on prisoners that didn't need root canals. And they did all these different, I swear to God, this is why we have human research committees, because these guys did this. They did it for 2.5 or 3 years. They would do, this one's short, this one's long, we're going to wait till it's necrotic, this one's going to be vital. We're going to fill it long, we're going to fill it short, we're going to fill it right at length. And then they would do block sections and do all the histology on it. So they're cutting a big fucking block of bone and the root tip out and looking at it histologically. And so that went on for 2.5 or 3 years. And finally, one of the dental nurses in the prison goes, "What are you guys doing? They don't need a root canal." And that was the end of the study. So, so what did they find? They found, like almost everybody else that has looked at this, there is a higher frequency of failure with overfilled cases. But do not mistake coincidence for etiology. The overfills are coincidental to the true etiology for the failure. All the cases that failed due to surplus filling material failed because the end of the root canal was destroyed by the horrible files they had at the time. If they're deciding, oh, we're gonna show what it's like to take a 45 file 2 millimeters past the end of the root canal. Well, if the canal starts out like this, it's going to look like this when you get done. It's totally wrecked. And in the middle of this destruction, this cone happened to sail past, and everybody goes, "It's got to be the cone." It's the classic bias confirmation, right? You're looking for an answer, you see an answer, you go, "That's the answer." Like, well, maybe it is the answer, maybe it isn't the answer. You got to look a little bit harder.
So you basically said that correlation and causation. So people saw failures when there was of an overfilling, but
Right.
maybe the origin of the failure was not the overfilling. What was the origin of the failure? Was the incorrect shaping of the canal, right?
The rape of the apical anatomy. So you take a canal that looks like this and you rip it open, nobody can seal that unless you're going to do something clever with MTA. If you ledge it, if the majority of cases that fail are undertreated, not overtreated. Okay, they block out. They have a bunch of junk in there that's infected. They block themselves out. They treat it 2 millimeters short, and then they end up having to cut the end of the root off in an apoectomy when it fails because they didn't take care of the entire root canal system.
Oh, I never thought about it. All the apicectomies we see, you
Mhm.
never see an apicectomy, like rarely you see an apicectomy with a piece of gutta perca beyond the apex. You always see a non-fill canal that they fill. We're going back to West's research, right? The thesis of West that he found that with every lesion there was at least one.
One untreated portal of exit, right?
Yes, I
Yeah,
tried to find this research online. I couldn't.
it's
They,
not
they didn't.
published. He didn't
It's not.
publish it. It was his graduate thesis. If you send him an email, I bet you he'd send you
I
file
sent him an
copy.
email. He didn't respond.
Oh, okay. Well, maybe I'll ask him to do that. Maybe
Because
next time I talk to him. That was a good
Castellucci,
study.
Arnaldo Castellucci has the photos in his lectures, and I was really wanting
Uh-huh.
to
Right.
to have the photos too because they're really good photos with
Oh,
diaphanous teeth,
it's great.
transparent.
I mean, one of them you see like the gutta percha cone is 2 millimeters short, and there's like three or four lateral canals beyond it. It's like, holy
Yeah,
shit, there's like 5 millimeters of canal that was untreated. So back to surplus filling material.
exactly.
To me, it never made any sense because all the materials we use, you can't use them in dentistry unless they've been tested to be biocompatible. That's one of our one of our first requirements is do no harm. So it can't be non-biocompatible. So we know our sealers after they set are biocompatible. Before they set, not so much. Gutta percha, it's relatively inert. It's not as good as a bioceramic, but it's the next best thing. And we also have bioceramics now too. So if those materials are all biocompatible, how could having extra material be deleterious to the outcome? It's not logical.
Can you go back to the prisoners because you started with the
Oh,
prisoners? So what happened?
oh,
It's really interesting.
okay. Okay, so what did they show in the research? Well, they showed as like a huge number of papers have looked at this. There's like 85 papers in the literature on the incidence of failure and overfills, and they all, it's a fact. Cases that are overfilled, grossly overfilled, are more likely to fail than cases that aren't overfilled, just because of the damage that preceded the overfill. So if it's an overfill that's surplus filling material going out of a lateral canal, and you have the master cone corked right next to it, and of course you can't control how much goes through the lateral canal. You have a big sealer puff there. It doesn't matter. It's biocompatible. It's going to be fine. If it's overfill of the master cone, that usually indicates a failure of the preparation. So it could either just be incomplete. Now, in the case in Oregon that I was telling you about, the shape wasn't wrong, it was just incomplete. The taper went down and it stopped about 2 millimeters from the end, and I just had a parallel spot there. So my cone wasn't binding at its tip, it was binding back there. Um, that's a case that's going to work. If I have surplus material in that situation, it's going to work out fine. If I have the canal had a curve and now it's ripped open and there's surplus fill material, that is going to fail more often. The failure, though, is not the obvious thing. It's like a head fake, right? So there's this big flag of gutta percha out there and a lesion around it. Like, what caused this? Well, it's not the gutta percha. It's what's still in the root canal. It's not sealed up. If they wreck the end of the root canal with bad instrumentation, they probably don't understand irrigation or obturation either. So, cascading events cause all human tragedies, and that's kind of how clinical cases go. That's why early mistakes are more devastating than later mistakes. There's a guy named Atul Gawande who wrote a book called Complications about surgical failures in the OR. And he said that failures accumulate during a procedure. And so that's why access has to be perfect, or you're never going to make it to the end of the case with your head held high.
You said
Oh,
that mistakes accumulate.
during
What was it?
procedures.
During
Errors
procedures.
accumulate during procedures. Yeah.
This is why our access needs to be perfect. Because in my course, when I teach, I have to do 2 days on access. Like 2 days, they're
Hmm.
doing access because, from my point of view, it is also the most important thing. And when they did the access, I just tell them like just take the tooth, take an 8 or a 10 file and push it, and it's in the apex. Like 90% of the time, it's in the apex if they did the access and the pre-flaring correctly.
One of the authors on this topic that I really appreciate, his name is Atul Gawande. He's at Boston Mass um, Hospital, Brigham Women's Hospital. I can't remember exactly what. Anyway, he's a brilliant guy, and he's written so many books on when things go wrong during procedures. And so, in dentistry, one of the reasons I like being a dentist is if I have a bad day and I wreck a tooth, they just lost a tooth. They're still walking around, they're alive, and there's no devastation behind me. So he's got bigger problems. He's got people dying in ORs, and they deconstructed them, and they started looking at all this separate procedures. And one of the things that came out of this was they figured out these guys are starting the procedure and they haven't even done a checklist to make sure they have all the stuff they need. It's like, then they compare it to taking off in a jetliner. do they just get in the cockpit and go, the last guy's probably checked this out. It's okay. We don't need to go through the checklist. Like, no, there's 300 passengers back there. You're all going to die if you don't do the checklist. But because it's only one patient that's going to die, they never did checklists before surgeries. And he actually wrote a book called The Check Fit List Manifesto. And he's probably saved millions of lives by instituting now hospital ORs. They have checklists. Nobody starts a procedure without everything checked off. And if it's a 6-hour procedure, they're going to stop. They're going to have an intermission in the middle, and they're going to do a second checklist for the last part of the procedure. So that's the intellect of this brilliant guy. The book that I'm recommending you guys read is called Complications, and he found that errors accumulate during procedures. You only have one error the first half hour, but that one makes it harder to do the rest of the procedure. So then you have a second one coming in at about 35 minutes, and it gets more and more intense until the failure actually occurs. What does that mean to us doing endodontics? Is like access is everything. I've been doing root canals for 45 years, longer than that if you count when I was in school. And by far the hardest thing I do is a perfect access. If I can do a beautiful MIE access with absolutely uh, no limitation on my convenience form. My convenience form is perfect, and I can save all the two structure possible. That's going to be a great case. It's going to turn out well either way. Even if it fails, retreating it is going to even be easier. So if you botch the access, it's almost impossible to make your way back to a successful result unless you really think hard about it. Um, there are different kinds of mistakes made in access. Uh, Perforation, obviously, is the one everybody fears the most, but the ones that really cause a lot file breakages and misfills are just incompleteness. Like you have a line angle that's in a nice position, but there's a little irregularity right at the orifice level that you haven't planed off and smoothed out. So when you're putting your files in, you have to go poke, 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 and then finally you drop into the root canal. If you're trying to treat a molar and you can't immediately slide all your files down the line angles and drop perfectly into the canals, uh, you're working too hard. You're not gonna enjoy it at all. So again, access is everything. That's just as you said. It's takes more time to teach access to students than almost any other part of the procedure now.
Mistakes in the beginning will cause more damage, and there's even a book about it.
Yeah,
It's amazing.
yeah,
It's
it's
amazing.
true. There's a lot of smart people out there. It's just really research. I hate to do research, but it's the most important thing that I do. Right. To me, it's a little boring. I'm going to look at what other people did. And, if you hold your concentration until you find out what they were really talking about, now it gets interesting. Like finding out that Sam Seltzer's research came up with the wrong conclusions. And here's the reasons. They're using these huge, stiff stainless steel files that could not go around a curve if you tried to make them. So they're going to wreck the end of the root canal almost every time you have a filling material flying through the end of the root canal. So if you understand the context of their conclusions, you can decide whether those conclusions still apply to your current experience. Okay.
I always say to my students, read the materials and methods, right? Because when I was reading research about the glide path, and there's few papers that say that glide path does not work and does not improve anything, and then you go to the paper and you read the materials and method, and they said, well, first we put a number 10 file to the apex, and then we worked it. And then you did the glide path. Like that was your
That's
glide
just
path.
that's just another rotary file. What are you talking about?
Yeah, yes,
Yeah.
it's like, and they try when you read the materials and methods, and you actually go into the research, you can find so many interesting things. How do people try to manipulate knowledge? How do they try to make us believe certain things that are more important for them, or that they are supporting their point of view?
Mhm.
There's an Italian friend of yours that really like one of them. Yeah,
Oh,
that you
don't
had a
go there.
debate with. No, we're not
Right.
going there. Some other day.
Yeah.
Steve has a great lecture about the patency, and he was crazy enough to cut a piece of his own tooth and to send it to a laboratory, the apex of his tooth, to win a debate. And this is
Hey, if you're going to do it to a prisoner, you should be willing to do it to yourself.
is this lecture on your website?
I think it is. Yeah, there's an edited version of that debate. My part, not his part.
Oh,
Oh,
can I say who it is?
absolutely. It's Dominic
So
Riccucci.
it's Domenico Ricucci. So there's you go to Steve's website. You can see the debate with Domenico Ricucci. I assume it's a great debate. It's a great topic. I'm not gonna take parts. You just assume what I'm thinking. I think it's one of the greatest myths. Maybe we're gonna talk about it today. Maybe we're gonna talk about it next time because many people are afraid of going out of the apex. Right? They're like, nothing should go beyond the apex. You put an implant inside the bone and it doesn't matter. But if you take out a 6 file outside the apex, the world will end. Right? It's like the
Yeah.
story with the filler.
hmm Yeah. If you're a histologist, it's really hard to be popular amongst clinicians. So if you're a histologist, you always look who benefits from this. Why are they raising such a fuss about this? It's because they don't have anything else to talk about. They just made it up. They want to be important. They want to boss people around and tell them how to do procedures they don't do themselves. And I really resent that because they victimize all the poor students of theirs that listen to their bullshit and change their procedures to be less effective because of it. It's just not right. It's ego driven education. Ego driven. Ego is the number one enemy of education is ego by educators.
So let's try to wrap it up for today. I
Yeah.
really enjoy, but
Okay.
I have a webinar in 30 minutes and I need to prepare.
All right.
I really I'm really sorry to end
No, I'm
this
fine.
conversation with you. And I'm not sorry for you. I'm sorry for me. I was enjoying it.
Good.
I was
Well,
really learning new things.
let's just do it again.
Let's do it again.
Yeah.
Thank you, Steve.
Yeah.
Thank
I
you
had a
very
lot of
much.
fun. All
Bye
right.
bye.
You take care. Thanks for setting this whole thing up.